concept and the exemplars. So that's, you pretty much have my template already, so that's how it's done. Or that's how any of us do it.
So I got this ulcers and this one.
Okay. So, elimination. Yesterday we talked about nutrition and getting in what we need, and elimination is all about getting out what we don't need, correct? So, elimination involves removing the waste from our bodies. It's the excretion of waste products from the kidneys and intestines, the GI system. Hey guys, come on in, sit down, and try to be quiet, okay? Where's the sign-in sheet going? So make sure you're here. Okay. So, listen up. You gotta move quickly so you guys can have a moment to yourself before you have to take your test, okay? So, as I said, elimination is the waste products from the kidneys and intestines through the GI system. Your objectives, concept, what do we have to have? We have to have a working bladder. Our GI system has to be working. We have to have been taking in or ingesting. We have to have a working GI tract that's processing, absorbing our food, producing waste in order to have waste to excrete. Bowel elimination is the passage or dispelling of stool through the intestinal tract by means of the smooth muscle contractions. Urinary elimination is the passage of urine from the urinary tract through the urinary sphincter and the urethra. Anatomy, the breaking down and absorption of nutrients from the foods we ingest, moves through the colon all the way to the rectum where it is removed from the body. Kidneys, for urinary, quick anatomy for the urinary system, kidneys, ureters, bladder, urethra, form urine, and it is same with bowel, peristalsis, colon, rectum, sphincter, and the anus. GI tract is responsible for the removal of the digestive waste in the form of stool, and kidneys are responsible for the removal of metabolic waste from the blood in the form of urine. Normally, excretion of urine and stool occurs under a voluntary control. The bladder can hold about 300 to 500 mils before it signals a need to urinate. Urinary elimination. Voiding. Urine collects in the bladder. The pressure stimulates and stretches the receptors, the detrusor muscles. It transmits an impulse to our voiding reflex center of the spinal cord, and the conscious part of our brain sends the message back to urinate. It's a conscious part of our mind to urinate. Reflex subsides until the bladder is full again to stimulate the reflex again. Voluntary control only if the nerves supplying the bladder, the urethra, the tracts of the spinal cord, brain are all working together. Patterns of voiding vary by individual. 5 to 6 times a day. Other key terms: defecation from the bowel, urination is urine, Continence is the purposeful control. Anuria is the absence of urine. Dysuria is painful. Polyuria is multiple episodes of urination. Frequency is multiple episodes but with little production. And hesitancy is difficulty in starting the stream. The neurogenic bladder does not perceive bladder fullness and is unable to control the urinary sphincters. Key risk factors. Infants, toddlers, and children initially lack control over the sphincter and the muscles that control urination and bowel elimination, but control is usually around 18 to 24 months before they are able to identify the urge. Pregnant women have, the pregnancy has an effect on elimination patterns because of the presence of the fetus. This affects both bowel and bladder function. As the fetus grows and increased pressure is placed on the bladder, frequent urination is required. A woman will also have larger volume of urine because she has a larger blood volume due to gestation. The growing fetus also can interfere with intestinal peristalsis and cause constipation. On top of that, prenatal vitamins with iron can also contribute to constipation in a pregnant female. Older adults have physiological changes associated with elimination, and usually by age of 60, renal flow reduces and the kidneys lose up to 50% of their functioning nephrons. However, this doesn't change the ability to clear the urine out. Older people are more susceptible to fluid and electrolyte imbalances, kidney damage due to all the medications we're taking sometimes. The bladder tone changes with age. The volume of urine that can be held is reduced, so that ends up being urinary frequency. And the muscles around the urethra become weak, so increased risk for incontinence. All individuals, regardless of age, gender, and ethnicity, are all potential risks for having some kind of bladder dysfunction or any kind of elimination issue. You don't have to be a certain age. Lots of medical conditions, cognitive impairment, altered mobility, especially in long-term hospitalization, spinal cord injury, brain injury, Crohn's disease, renal stones. Risk factors: children younger than 3, the elderly, the pregnant, and women who are menopausal. 19% of women age 45 were 49% of women over 80. Specific problems are urinary calculi, enlarged prostate in the male, acute infections, chronic infections, congenital issues, medications, also things such as stroke, spinal cord, diabetes neuropathy, dementia, AIDS, Alzheimer's. Women are prone to incontinence, stress incontinence, because of weak pelvic floor muscles. Medications such as diuretics also can impact that risk. Any kind of infection, trauma to the brain, spinal cord, all are risk factors. Individual risk factors include conditions such as neurologic impairment, mobility altered, cognitive impairment, immunologic impairment, people with trauma to the brain, spinal cord, stroke, spinal cord injury, AIDS, retention, bladder retention, incontinence. Bowel elimination, normal bowel elimination, defecation, expulsion of the feces from the anus and rectum, also called bowel movement or stool, frequency and volume highly individualized. Volume and consistency vary due to nutritional intake. dietary consumption, and intestinal transit time. Peristalsis, normal feces, 75% water, 25% solid material, soft form, require normal fluid intake. 88% or 8 million Americans are at risk for an altered bowel elimination. People highest risk for incontinence are, again, same with urinary, people with cognitive impairment, exposure to radiation for treatment purposes, taking multiple medications, consuming excessive amounts of caffeine, stroke, spinal cord, diabetic neuropathy, autoimmune diseases, GI system problems such as irritable bowel, Crohn's, food allergies, food intolerance, celiac disease. Several congenital defects also in the spinal cord, brain, colon, and rectal defects. Risk factors for stool retention: lack of adequate fluids, fiber, and exercise, use of medications, pregnancy, same medical conditions we've been talking about, and some conditions are specific to the GI system, such as the food allergies, intolerance, and some of the congenital defects. Alterations include diarrhea, which is passage of liquid feces with increased frequency, urge to defecate difficult or impossible to control, cramping, increased frequent bowel sounds, fluid and electrolyte losses, risk of skin breakdown, flatulence, excessive gas due to bacteria action, swallowed air, gas diffusing from the bloodstream, foods, abdominal surgery, myocarditis. Constipation, passage of less than 3 bowel movements a week, or difficulty in passing stool, it's hard and it's dry due to decreased motility, slow movement of the feces, and it may reflect primary problem or underlying disorder. Bowel incontinence, inability to control passing of feces, intestinal gas, usually manifestation of another disorder, such as neurologic, depression, trauma, inflammatory, also with masses, hemorrhoids, or deformity. We doing okay? Everybody out with me? You always know that, you all might remember Arnold Schwarzenegger was called the Eliminator. It seems like no matter what level I teach on, I get the elimination lecture, so I'm calling myself the Eliminator now, because that's how I always get stuck with this topic for some reason. So I'm the Eliminator. We all have to discover all things elimination. So lifespan considerations, newborns and infants. What is one thing we're concerned about with newborns when moms of water breaks? Meconium pain, correct? Frequency varies with infants. Which do you think has more, breastfeeding or formula? Breastfeeding babies typically have more stools. It's usually the consistency is also a lot softer or more fluid-like than with formula. Color varies, consistency changes to firmer when they start food. Toddlers, daytime bowel control, typically by 2.5, thereabouts on average, some earlier, some later. School-age children, bowel habits are similar to adults by that point in time. Frequency, quantity, and consistency varies. I know as a school nurse, I saw a huge increase probably the last 5 years that I was a school nurse of encoparesis, where children have a problem with holding their stool. I had all of a sudden had a lot more students with that. Pregnancy, increased progesterone levels, delays gastric emptying, delays peristalsis, may lead to bloating, constipation, enlarging uterus, aggravates the symptoms, hemorrhoids late in pregnancy, bowels are sluggish after giving birth, pain may lead to delay in elimination, flatulence after cesarean birth. So the fetus puts increased pressure on the bladder, causing increase in urination, increase in volume, and constipation, and the prenatal vitamins are frequently a complaint of causing constipation. Older adults, constipation is very common. I know when I was working in long-term care, the most important record in the facility was what? We called it the BM book. I don't know what you guys called it, because you always wanted, if I hadn't been on in a couple of days, first thing I wanted to know was, okay, when was the last time people went? So that the record of a patient going to having a bowel movement. So it's very important in the older population, and anytime you are in the hospital or long-term care setting or home health setting, you need to make sure you keep an idea of what their bowel movement status is. So due to reduced activity, inadequate fluids, because remember they tend not to drink. And when you tend not to drink, you tend to have harder stools, and harder stools are what? Hard to pass. And when it's hard to pass, then people don't put out the effort, and then they end up getting what? They get an impaction, right? So older adults, you really have to be watching all the time and keeping a track of what's going on, especially if they have cognitive dysfunction. Muscle weakness, medication side effects, remember polypharmacy. Laxative use inhibits natural reflexes, especially if they have been taking lots of laxatives for a long time. What happens? They don't go on their own, right? They need a laxative to stimulate them. So change in bowel habits over several weeks need to be referred to the primary care. Urinary incontinence problems, different types of incontinence. Incontinence is the loss of control, loss of involuntary release of urine or feces, leads to skin breakdown, changes in the daily activities, and changes in social relationship. Urinary incontinence is this disruption of the storage of urine or emptying of the bladder with involuntary release associated with the external or internal sphincter. It can range from light leakage with a sneeze or a laugh, or to all the way to full loss of continence. Factors also such as psychological factors of depression, cognitive impairment, and any physical surgery and such can impact. But there's stress incontinence, urge, overactive bladder, functional overflow because the bladder is too full and not getting that message to urinate, can be transient. The cause for urinary retention is the external sphincter does not open for release of the urine, or there's a blockage in the urethra, leads to increased urine volume and bladder distension, backflow into the upper urinary tract, dilation of the ureters and the renal pelvis, pyelonephritis, renal atrophy. Also, always have a risk of infection. Bowel incontinence problems, occasional leakage of stool while passing gas, complete loss of bowel control, incontinence due to cramping, complete incontinence from loss of sphincter control due to traumatic injury, pathological changes in the rectum, and from a neurological injury, changes in loss of cognition, many times results in bowel incontinence. If you keep a patient on a regular schedule, you can usually maintain their continence a little bit longer, even if they do have cognitive issues. Bowel retention. It begins, one of the biggest things it begins with is ignoring the urge to go and decrease peristalsis. Leads to retention of the stool in the rectum. The stool hardens, dries, constipation, impaction develops. Causes loss of appetite, causes discomfort, and this is the fecal impaction. Also, side effect of medications. Common diagnostic tests, urinalysis, blood urea, nitrogen, creatinine culture, occult blood. We're looking for how well the kidneys are working with the BUN and the creatinine. Social lifestyle, relationship consequences, potential for falls, depression, withdrawal, constipation, pain, loss of appetite, nausea, and vomiting. With the bladder, we're looking at pain, chronic bladder infections, bladder distension, urinary reflux back into the ureters, polynephritis, renal atrophy, renal failure. All of these things we're looking for with our tests. Assessment. Their normal urinary bowel elimination and any changes that they've had. I always assess the patient for the frequency, the appearance of their stool and the urine, any associated symptoms, alterations in their pattern, changes in the appearance, changes in the frequency or the quality. Have they suddenly developed diarrhea all the time? Discomfort or difficulty with eliminating? Have there been changes in their diet that explain this, or changes in their health status? New medications, new conditions, have they had a change in their functional ability? Voluntary or involuntary emptying of the bladder? That's, and also, adults don't report urinary incontinence, so it is an underreported phenomenon. Assessment, inspection. Your abdomen, genitalia, perianal area, auscultations. We're listening for bowel sounds. Palpitation, looking for distension. Any sign of mass or impaction. Digital palpation, prostate exam, percussion, identifying gas, masses, anything abnormal. Absence of, if they have decreased bowel sounds, absent bowel sounds, hyperactive bowel sounds, distended bladder. Primary prevention is hydration, adequate dietary fiber, regular toileting practices, consistent time, regular exercise, avoiding environmental contaminations, such as contaminated food or water. Now, if you get a nice bacteria, GI bacteria, you're going to mess your life up for about 2 or 3 days, correct? Encouraging increased intake of fluid and fiber. Teaching about the impact of dietary choices. Bowel training if that's needed, especially if someone is having incontinence issues. Pelvic floor exercises. Biofeedback and personal hygiene. Other things are not smoking, decreasing the caffeine. Secondary prevention, the dreaded colonoscopy screening at age 50. Also occult blood screening, prostate cancer screening for males. The colonoscopy is started at the age of 50 and if it's all clear, then once every 10 years, so they're 75. Occult bloods anytime there's a digital exam. Prostate is given on, for males on a regular annual physical. Interventions, treatment strategies depend on the underlying condition, but the most common is pharmacotherapy, incontinence or retention management, and surgery if necessary. Pharmacotherapy for bowel includes laxative, that includes bulk forming, bowel stimulants, lubricants, saline laxatives, stool softeners, antibiotics, antispasmodics, as in irritable bowel syndrome, Imodium, analgesics. The drawback from meds for stool retention is that they should be used as a last resort and as short a time as possible. Why? Why would we give medicine for stool retention? You don't want to do it long, and you don't want to try it that first. Because they get dependent on the laxative. So we try other things first. And then go to those as the last resort. Urinary antibiotics, especially for UTI, based on the CNS. Antispasmodics for urinary incontinence. Analgesics as needed for relief of discomfort. And the alpha adrenergic blockers, diuretics. Incontinence management, bladder and bowel retraining, biofeedback, timed and prompted voiding, use of protective pads. Skin care is a real issue anytime there is incontinence. Other skills that may be involved in management are urinary catheterization, suprapubic cath care, catheter irrigation, enemas, NG tube for gastric decompression, ostomy care, and medication administration. All of those are skills that are involved in incontinent management. Bowel, colectomy, removing the portion of the bowel, colostomy or ileostomy diversion, rectal prolapse repair, and hemorrhoidectomy. Some of the common surgeries. Urinary surgery may include prostate surgery, bladder surgery, urinary diversion, surgery for renal calculi, and stents for relieving obstructions. Interrelated concepts: acid-base, fluid, electrolytes, nutrition, cognition, mobility. All those concepts have an impact on elimination. Everything you wanted to know or didn't want to know about elimination. Any questions?